Good morning, everybody. Let's go ahead and call today's Health and Hospital Committee meeting to order. I am audibly serving as your chair of this committee, along with my vice chair, Supervisor Margaret Koga. Since both of us are here, we have a quorum. All right, item number 2 for public comments. This law does not permit committee action on extended discussion on any items that's not on the agenda except under special circumstances. And this is the time, if you want something to say about that's not on this agenda, this is the time. Go ahead and turn in your note card, or Jess, anybody online?
I do have one speaker online. Holding at one.
One. Okay, let's do 3 minutes, please. Thank you.
Thank you. Our speaker is Parent. You'll have 3 minutes to speak. Timer will start when you begin speaking. I'm sorry, I can see that you're speaking now, but we're not getting the audio. There you are.
Good morning. I believe that we have an undeclared public health crisis here in this county with regards to children being molested. And I believe that this is being supported and this is being facilitated by the district attorney's office, specifically Jeff Rosen. You can see it with the story on Dr. Patrick Klein, how he failed to prosecute him or report him to the medical board. And as a result, he was allowed to continue abusing more children. And you could see it just recently with Saul Duran. He failed to report him to CPS for having inappropriate relationships, and he admitted that he knew personally that he was having inappropriate relationships, and he didn't report it. And then there's countless other parents who have reported abuse, and Mr. Rosen has failed to take any action. You're welcome. Including failing to provide screenings for parents begging for a screening. And my own kids are being sexually molested. I mean, nobody's willing to do anything about it. I mean, some of you here are mandated reporters. You won't even help me because Jeff Rosen says it's okay. And if he says it's okay, then the whole county has to ignore a parent. I mean, look what happened to Valerie Ray Berry. I mean, this was reported nationally. I mean, if you Google Valerie Ray Berry, Santa Clara County, you'll see how Jeff Rosen, he knew that the husband was molesting the child, and she tried to protect the child, and then she fled to another state, and he extradited her, and he put her in jail for an entire year for violating a court order. When the offending parent, he admitted to DFCS that he stuck his head between the child's legs while bathing. I mean, he's doing some very horrendous things, and he's setting terrible precedents. And I mean, my kids are gonna suffer, their children are gonna suffer, and I mean, and the grandchildren are all gonna suffer because he says it's Valerie Houghton is involved. She helped him with his election. She supported him. So now he has to repay the favor, and that takes precedent over protecting my children. It's just terrible what's going on. I hope that you guys will declare a public health emergency. Thank you for your time.
That concludes public comment.
Thank you. And California law does prohibit the disclosure of information relating to investigation of suspected child abuse and neglect. As a result, we're not authorized by law to speak to the specifics of any particular case or result of any investigation. California law requires child welfare departments to immediately cross-report physical and sexual abuse of children to law enforcement, and the public should be assured that our county does take all allegations of child abuse and neglect seriously and takes appropriate action. Thank you. All right, moving on, we have item number 3, which is approval of the consent calendar. And I think we do have a few items that we probably can put on consent today. So to start with, I would like to ask to my vice chair if I could put 10, 11, 12 on the consent. Okay.
And then may I ask that we hear 7 and 8 together?
7 and 8 together,
Regarding the EMS update and
correct?
then with that, I'm happy to make a motion.
Sure, I'll go ahead and second it. Let's see if there's any public who'd like to speak on this item.
Confirming there are no requests to speak on the consent calendar.
Okay, so those items we talked about, so we're talking about moving 7 and 8. We're hearing those two items together. Item 10 is the monthly report from the Office of Veteran Services relating to Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. On that specific note, I just wanted to thank our VSO responding to our questions earlier, and glad that the recruitment's underway to replace the 2 social workers that left, and the number of enrolled veterans is on track to surpassing the original goal of enrolling 100 veterans on 10. 11 is to receive a report from the Santa Clara Valley Healthcare relating to efforts to address improper disposal of medical waste and confidential patient information. And for 12, that we also put in consent is the acquisition integration of regional medical center. I think a lot of that could probably be incorporated later on when the hospital CEO could report with Paul later on. So we could talk about that. All right, on that, I'll second that motion, and let's take a vote.
Thank you. Could I ask you to be closer to your
Oh,
microphone?
sure, my bad.
Thanks very much.
Thank you.
Vice Chairperson Nabe-Koga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Great. All unanimously passed. So let's move to item 4, which is recommendations relating to the medical staff and allied health professionals at the Santa Clara Valley Medical Center, O'Connor Hospital, St. Louis, and also Regional Medical Center.
I was informed that Dr. Salmon would be here virtually, but I don't see her in the webinar.
I can,
Yes, go ahead, Paul.
Chair Lake can take
Please.
this item. So the medical staff is requesting your approval of the medical staff and allied health professionals
Okay.
items.
It's fairly standard. Do I have a motion?
Motion to approve?
Motion, Vice Chair. I'll second it. Do we have any public comments?
I have no request to speak on item 4.
Okay, so I guess motion seconded. Let's go take the vote.
Vice Chairperson Nabe-Koga.
Aye.
Chairperson Lee.
Aye.
Thank you.
Thank you. Moving to item number 5, which is the recommendations relating to federal and state health policy and budget landscape.
Thank you, Chair Lee. I believe we have Bert Mungolan on the line.
We do.
Good. Ms. Margolin's on the line.
We'll get him pinned shortly. Bert, you'll have to open your microphone. I see your video. Can you unmute yourself?
Just did it. I hope.
There we go.
Am I on now?
You are.
Good morning, Ms. Margolin from the Margolin Group. Good morning, Bert.
Morning. So, the biggest issue before the Congress, and really the only issue before the Congress right now, is the prospect of a government shutdown next week. Democratic votes are needed because of the 60-vote margin in the Senate. And the Democrats have made a series of demands, though, as a condition for their votes in the Senate and the House. And the demands are focused on health issues. There are 2 main baskets of requests. The first involves restoring the Medicaid cuts in H.R. 1. And the second area of demand is to extend the enhanced premium tax credits that are the subsidies that help make policies provided through Covered California and other healthcare purchasing exchanges more affordable. They are currently set to expire at the end of the year. Nobody in DC believes that there is a real possibility that President Trump will reverse his posture at least now on the Medicaid cuts. The goal of the Democrats in making the demand that the cuts be reversed on Medicaid is to highlight once again how damaging these cutbacks will be. It's a moment in time for Democrats to capture national attention and focus on the many ways that H.R. 1 will weaken our healthcare delivery system. So they're going to be demanding Medicaid reversals. Again, highly unlikely they'll gain any traction there, but it's an important moment in time to make the case. The tax credit issue is a much different story. Many in DC believe that there could be a deal eventually on restoring the enhanced premium tax credits, in part because they disproportionately impact red states. Several Republicans are already asking for a fix on this issue. Let me just very briefly review the history of the premium tax credit issue, since this will be at the center of the likely government shutdown. They were, the tax credits were part of the original Affordable Care Act. They were designed from the beginning to operate as part of the national system of state-run purchasing exchanges. Our California exchange is called Covered California. People who receive insurance through an exchange pay a discounted premium because of these credits. Prior to 2021, the tax credits were available to individuals or families whose income was below 400% of poverty. And to make that number or that percentage clear, for a couple today, a two-person family today, that's roughly $85,000 a year. So again, prior to the enhancement, you only were eligible if you were a couple, less than $85,000 a year. In 2021, when COVID hit and the American Rescue Plan was passed, the structure of the credit was changed, and the credit was made more generous for the lowest income enrollees. And the tax credit was allowed to apply for the first time to individuals above 400% of poverty, to people who made more money, but who still would struggle to make to find the funds to pay the cost of health insurance premiums. The change was triggered by COVID, but it was really, the pressure for it was building over many, many years, because exchange enrollment was moving along much more slowly than people would have liked, because far too many people were still being priced out of coverage. So the American Rescue Plan created the enhanced tax credit. The Inflation Reduction Act extended that credit through the end of 2025, expires end of this year. The impact, as I said before, of not extending these credits will be quite severe and very hard for Republicans in particular to avoid responsibility for. These credits are given credit for doubling enrollment in the exchanges since 2020. They've been especially impactful in red states. In Texas, for instance, the number of people in exchanges has increased by 255% just in the last 5 years. And in Florida, there's been a 147% increase in people covered in the exchanges. So Texas and Florida are the most impacted states, both red states. If these credits go away, a major loss of coverage, or if coverage is to be sustained, very painful increases in the cost of insurance. More than 20 million Americans will face these higher premiums next year, and these are people in the exchange system. But it goes beyond the exchange, because when you increase the number of people who are uninsured and destabilize the insurance market, everyone who has health insurance is affected. Their policies are all affected, and so the impact goes really to everyone in the country who has health insurance. The most extreme impact on people in Covered California and the exchanges, but impact for everyone with a health insurance policy. Kaiser Family Foundation, which is the gold standard for analyzing national health policy, estimates that exchange member premiums could increase nationally by an average of 75%. Talk about sticker shock. That's an incredibly large amount and very hard for people to not notice and be angry about. The Congressional Budget Office estimates that next year alone, nationally, 2 million people will drop their coverage because of these extreme premium increases. And over the course of the next several years, a total of 4 million people will not be able to afford coverage. Just one final note to more fully flesh out what this means. Kaiser Family Foundation provided 2 examples recently of specific types of enrollees in the exchange and how this would impact their premiums. The first involves a 27-year-old single person, makes $35,000 a year with the exchange, with the enhanced exchange credit, pays $1,033. If the enhanced credit goes away, that same single 27-year-old person is going to pay $2,615, a 153% increase. I mentioned the age because these premiums are adjusted by age within certain limits. The second example I'll cite is a family of 3, a couple both age 49 with a 19-year-old child. They make approximately $90,000 per year. they would see their premiums go from the current $6,246 per year with the credits to roughly $9,000 overnight, a 44% increase. These are sharp increases. They'll create confusion and anger, and it's easy to see why Republicans don't want to own these increases. Now, in Santa Clara County, the loss of these enhanced credits will clearly have an impact on the number of people without health insurance. There's likely to be a rapid increase in people dropping coverage. While they will drop coverage, of course, their need for health care will not disappear. They will still seek care in our system, but without health insurance, a major setback for our system. A growing list of Republican lawmakers understand how indefensible this is, and you have people like Senate Leader Thune and Speaker Johnson both openly discussing the possibilities of doing a fix, but both are saying they will not do a fix. They're encouraged by the president in this around the October 1 battle over the budget. They'll do it later in the year, but not now. The fact that they're open to a deal at some point is the reason why many believe there's a chance that some action can eventually occur involving the enhanced tax credits, but not in time to avoid a shutdown. It's just not going to be no time for it and no political will to deal with it. There was supposed to be a negotiating session with Democratic leaders and President Trump this week. As you may all know, the president abruptly called it off. The Republicans appear to believe that a shutdown will hurt Democrats, and they don't want to negotiate right now. Now, that analysis is based upon historical experience. Over the last decade or two, when shutdowns have occurred, it is true that the party that triggered the shutdown typically is damaged by it. But that history may be irrelevant to the current environment for all sorts of reasons. We're dealing now with a battle between the Congress and the president over these massive health care cuts. We have a DOGE process underway, dismantling the federal government. We're in a much different period of time. And the Democrats believe that, on the other hand, that accepting a CR, even a short-term continuing resolution without elevating for the public the danger to Medicaid and the massive rise in premiums heading towards millions of policyholders within a matter of weeks is just unacceptable. Their conviction about this is bolstered by the fact that, and you may remember this, last spring there was a battle over funding through CR, the government, and the House wanted to not fund and provoke a shutdown, and Senator Schumer decided not to do that and he and several other Democrats voted for the CR. They got nothing for it, and there was significant Democratic pushback and protest, and members became very angry. And again, the lesson of that experience was there was no reciprocity from the administration, no concession, no slowing down in their drive to shutter government agencies. So a shutdown is virtually certain. How long and how we get out of it is unknown. The longest shutdown in history was 35 days. It occurred in late 2018, early 2019. Trump's first term was over the funding of the border wall. So important to note that mandatory spending, which includes Medicaid and Medicare payments, are not stopped during a shutdown. During a shutdown, the only staff of federal agencies that are deemed essential by OMB will be allowed to work. Democratic opponents of a shutdown, and there are some, have argued, as Senator Schumer did last spring, that if we do a shutdown, Trump's OMB could create targeted havoc by deciding who is essential and who is not, and would increase the power of OMB. And in this shutdown scenario, there's even more evidence of a very negative agenda by OMB, in that a couple of days ago, a memo was leaked that showed OMB asking federal agencies to develop a reduction in force layoff scenario to be implemented during the shutdown. Not just the normal furlough where you're off without pay and then later on the pay is provided retroactively, but the OMB strategy now is to use the shutdown chaos to say, well, and this is in fact what Russ Vought has said, the OMB director, we'll keep the essential workers, but if you're deemed non-essential in the shutdown, you can be fired, and you should be fired, which of course is a false analysis, a false analogy on several levels, and it's obvious, I'm sure, to all of us why it's false. But again, this is sort of a threat being made to the Democrats, but Schumer and the Democrats are undeterred by this threat. Their attitude is that this is an effort to dismantle, that this effort to dismantle the federal government has been going on for months now. And whether it's done under the cover of a shutdown or without a shutdown, it's continuing. And they've got to make a stand now, and especially over these enhanced premium tax credits and whatever other concessions they can get, try to make a fight out of it. We continue to track the status of the dish cut extension. These are the special payments Santa Clara County gets by virtue of treating a disproportionate number of Medi-Cal and uninsured patients. There are these big cuts that have been deferred for many years. There's an extension of the deferral of the cuts that has bipartisan support. It was included, this deferral, in both the Democratic and Republican versions of a continuing resolution, a CR, that was put forward last week. So I mentioned this only to underscore that there's still bipartisan support for the dish deferral, and we continue to believe that ultimately it will be addressed. So while missing the October 1 deadline for dish is not going to cost any immediate dollars, will not cost us any immediate dollars, and will likely never have a financial impact on the county because these payments flow on a delayed basis, and we expect and assume that there'll be a fix long before the payments would have been impacted. There is one provision that the Congress is dealing with that needs to be extended that could be impacted could impact us more immediately, and that is telehealth flexibility under Medicare. That was created during COVID as an effort to allow patients to be seen remotely. It's been enormously successful. Santa Clara County and other systems have made extensive use of it. That flexibility expires on October 1, and there is an argument that if there's a government shutdown, during the days of the government shutdown, those telehealth visits would not be reimbursable. So there could be a consequence on telehealth. Not totally clear if that will be the case, but I'm flagging it now because it's an issue that people in Washington are trying to figure out right now to see if there's a way to keep those payments going, and they're not sure they can actually make it happen. While this is not a budget issue, I do want to flag briefly one other major federal development that we've all taken note of, and that is the disturbing public health actions taken by the federal government over the last week. The vaccine advisory panel creating confusion and anxiety with recommendations not backed by scientific research on a range of vaccine issues, and a media event at the White House where the president and Secretary Kennedy offered a number of unsupported assertions regarding autism. I'm not going to talk further about this for additional guidance and insight on this issue. Should the committee seek that guidance, Dr. Rudman is obviously the expert who should be responding to these questions. Last comment I would make, at the state level, HR 1 response still has been very limited. There were some dollars approved at the end of session to deal with the loss of funding for Planned Parenthood and to support gender affirming care, but no plans for a special session, and a major state plan to deal with HR 1 and its impact is likely going to be deferred until next year and when Governor Newsom presents next year's budget. That completes my presentation. Happy to respond to your questions and comments.
Well, Bert, you're full of good news this morning, huh? Boy, oh boy. All right, let's see. Do we have any public who'd like to speak today?
For all of item 5, I have no request to speak at this time.
All right, let's close that portion. Vice Chair, do you have any questions with this issue?
I'm speechless.
Really?
So I don't have any for Mr. Margol. And I did have a separate question. I don't see our IGR team, but I had a question regarding the HR 1 and effects, and whether there are other counties or cities in the state that are doing revenue measures or other strategies to try to respond to the HR 1 cuts.
Sure. So obviously it's an off-cycle year. So we had the assessor special election.
That's right.
In the absence of that, it's unlikely we would have proposed something for November of 2025.
Yes.
So it's not surprising that other jurisdictions who didn't already have a scheduled election. That being said, Washington Hospital in Alameda County has placed a parcel tax on the ballot in direct response to HR 1. So there is one concrete example there. At least 3 hospitals in California have announced their closure or impending closure as a result of HR 1, including a hospital in Glenn County, Inyo County, and Hazel Hawkins Hospital just to the south of us in San Benito County had its deal to continue operation fall through. So the implications of HR 1 are already hitting, and there is at least one other example of a jurisdiction that has put forward an item. I would not be surprised to see other actions in 26 when there's a normal scheduled election. Of course, nobody knew about the Prop 50 item in time to, the deadline.
Yes.
The deadline to place an item was August 8th.
Yep.
So, the legislature, of course, could waive that, but others couldn't. So we've gotten that question in public a few times, but it's not surprising, given that there was no regularly scheduled election, that other counties wouldn't. As far as cities go, HR 1 doesn't have any significant direct impacts to cities, so it's not surprising not to see city impacts. I will add a couple other things, though. Los Angeles County, which has a slightly larger but somewhat similar major public hospital system, has come out with estimates of about a $1.85 billion revenue impact. So that's, quite, we don't know the details of the methodology, but it's actually quite in line with what we've been projecting. And so, their own estimates are consistent with the fiscal picture that we're looking at here as a county. So that's the update that I have on that.
Thank you, Chair.
Thanks for the report. And James, I don't want you to do any off-agenda report, but I certainly would like to learn more about the 3 counties, Glenn, Indio, and you say Hazel Hawkins. And also,
Yeah, those aren't county, those are private hospitals,
Oh,
just
those
to
are
be
okay.
clear. But yeah,
Right,
but those are examples of what we're already seeing happening with
because of
hospitals. Yeah.
H1. Now, with Hazel Hawkins, do you think there'll be impact to St. Louis? in that southern part?
Absolutely.
Right?
I mean, we're the next nearest facility. We already have San Benito residents, certainly those who need more higher levels of care coming to our facilities. So yes.
So maybe it's worth a discussion to see what that impact would be and how we might need to up the capability of St. Louis to make sure that they get covered. But that's something maybe Paul could discuss, not necessarily today, but we can future discussion as the
Yep, we
dates
can
and
provide
clarify.
an off-agenda report to give you
Please.
some sense of the impact that we're anticipating.
Yes, thank you so much, Paul, for that. There's a lot to unpack from what Ms. McGowan has mentioned regarding the shutdown, and certainly this is way above our pay grade in terms of what a shutdown will happen. But I am extremely concerned about this specific shutdown because of the threat that, unlike previous shutdown, folks might come back to work, week, 2 weeks, 3 weeks later, they go so-called furloughed, and they get all the back paid back. So there's really no financial impact to the employees. It might be delayed. This time around is different. They're talking about massive firing, and with what DOGE has done to the federal government in the last few months, this seems to be a continuation of DOGE, of cutting staff that they couldn't fire at the time. So I am very concerned about many of the thousands of folks who are working for the federal government, not just those in DC, but this is nationwide, in all departments. So I'm certainly very concerned about their livelihood and whether this is another way of getting around those to get people fired. And so I'm just making that point, number one. Number two is regarding the issues of some of the autism claim. This just past week, there was a claim about Tylenol being unsafe for pregnant women, and how vaccines, further laying doubt of the MMR vaccine with autism, and how that's also changing the policies around the COVID vaccines schedules and whatnot. Certainly, many of these claims are based more on correlation than causation, and there's a big difference in between those two. And I certainly think we need to do a better job of telling the world what there's a difference between correlation. The fact that A happens doesn't and leads to B does not mean it leads to B. A happens, B happens sometimes for different reasons. And so I think there's a point of the correlation versus causation. It's something that need to be explained and taught, and I'm thinking maybe something that we could help provide in the future in some simple one-pager cartoon, whatnot, to make it easy for people to understand the difference. Because this is what's sowing the seeds of doubt and confusion of millions of Americans and people, honestly, worldwide, look at United States as a leader, as a trusting expert on these issues. And a lot of these things that we know are not researched, it's not scientifically backed, and that's why it's so dangerous. Now, one thing I'm going to ask Dr. Redmond, you're the expert on this. I'm not. I'm just a lawyer. So could you help share some of these claims and share some facts with us, and also how we could potentially move forward in creating these information in order to help fight against the disinformation, against the claims of the safety on MMR or flu or COVID vaccines?
Yeah, well, thank you, Mr. Chair. I mean, I think there's so much to address here. And part of what is so important is that not just the people of Santa Clara County, but the entire country deserves accurate information to help make health decisions. And what we're seeing, sadly but not surprisingly, coming out of the federal government is the exact opposite: oversimplifications and frank falsehoods. So I'll touch on just a few, but I recognize that an important role of the Public Health Department is to help get accurate information to the people who live, work, and play here so that they can take care of themselves and their families. I think most important to start with, any connection between vaccines, especially the MMR vaccine, and autism has been debunked. And this is an example not just of misunderstanding or misinterpretation. There were false data published now decades ago that have been retracted, that resulted in someone losing their license, that describe that link, and over and over and over again, excellent science has disproven it since then. There is no link between autism and vaccines. Now, what is especially tricky is there's a more complicated story when it comes to Tylenol, and so I appreciate you flagging the correlation is not causation. I know Dr. Ananoria, who you'll hear from later, probably perked up when he said that. He has taught decades of public health students exactly that message. The version of that I was taught is Switzerland has the highest rate of chocolate consumption and the highest rate of Nobel laureates, but that doesn't mean that eating chocolate will make you a Nobel laureate. So
That's a good one.
Thank you.
Although I do like to eat more chocolate. That's
you
a good
can
excuse.
try. I won't
That's a
stop
great
you from
excuse.
trying. I won't stop you from trying. But I think, in this very, very serious example, there were some really well-conducted, thoughtful studies that found an initial signal saying in some cases, folks who use Tylenol more during pregnancy may have a tiny increase in the likelihood of autism in a child from that pregnancy. But then further, more rigorous studies looked into it. Some of them found the opposite. Some found that Tylenol seems to be slightly protective. Some of them found no association. And one very rigorous study found when you take out considerations like family context and genetics by looking at siblings whose parent had different amounts of Tylenol consumption during their pregnancy, there is no association. And so what we think has happened here is one of those situations where that correlation, that link, doesn't actually mean causation, doesn't actually mean Tylenol makes autism more likely. There may be a component where fever in pregnancy makes autism slightly more likely, and we understand why that might result in someone needing to take Tylenol. But we don't know whether that pregnancy might actually be safer if that person takes Tylenol as opposed to not. And we know there are very many indications when Tylenol is absolutely the right medication to take in pregnancy. But I think most importantly, autism is complex. The science behind it is complex. There's a lot we do understand and a lot we don't. And the families who have family members impacted by autism spectrum, adults living with autism spectrum on any end of whether it can be disabling or frankly just offer them a neurodiversity that's often brilliant and wonderful. Everyone along that level of experience deserves accurate science, and more importantly, deserves the resources and the environment that supports people of all abilities. And this sort of travesty of science coming out of the federal government takes away from the more important conversation that folks of all abilities deserve resources based on those abilities.
Well, thank you very much, Dr. Neumann, on that. I certainly do look forward to seeing some work maybe from your public health department to come up that information. And I think what you talk about, Switzerland and chocolate, I think those are the type of messages we need to get out to people because it's easily understandable and how important it is to not to mix those things up easily. Number one. Second thing is the issue of Tylenol. Even though what the federal government has said this past week, it certainly has no impact to what we do in terms of prescription and giving those to our patients right now, correct?
That's right. So, I mean, pregnancy is a complex time for people's health. And so one of the most important things anyone who is pregnant or may be pregnant or is seeking pregnancy can do is make sure they have access to medical care and make sure they're getting the prenatal care they need. And it's in those care environments where folks can have the right conversation with a doctor or nurse about when is the right time to take Tylenol or other medications in pregnancy, what should be avoided, and other important ways to keep a pregnancy healthy and keep a pregnant person healthy. So these guidances coming out this week, or these sort of half-truths, have not changed any of the expert guidance for pregnancy care, for postpartum care, for pre-pregnancy planning. And what is wonderful and heartening is that a number of true expert societies have put out really good information. One is the Society for Developmental and Behavioral Pediatrics, has put out information on healthy pregnancies and related to autism spectrum disorder. Another is the American College of Obstetrics and Gynecology, continues to be our expert society that looks at the best science and helps people keep pregnancies and pregnant people safe. And our own healthcare systems, our healthcare partners throughout the county continue to know that and continue to follow that best science to help keep our pregnant community members healthy.
Good. Thank you so much on that. And then moving on to the changes of policies of the vaccines and COVID or childhood vaccine schedule. With these recommendations that we're seeing from the federal government, has that affected what we're doing here locally?
Yes and no, and I'm prepared to go into more detail during the health officer report if you
good.
prefer.
We can do that later on, sure.
The short answer is, through, frankly, heroic, thoughtful, but incredibly labor-intensive work at the state level and here in the county, we are fortunately able to continue to offer COVID vaccines and other vaccines to everyone 6 months and older who wants them. And I will share more details about how we got there and what that means for people who want to get vaccinated this season. But I will also add that it shouldn't take us the amount of effort it has to overcome incorrect and non-scientific recommendation and guidance from the federal government in order to keep access to safe and effective vaccines here in Santa Clara County. And so, in short, yes, these federal actions do have impacts for us here and home, and we're working hard to make sure those negative impacts are minimized and we can continue to get people the vaccines they need.
Good. All right. Thank you very much, Dr. Drummond. This is very, very helpful. And I just want to thank you and your team for your good work to make sure that these very important preventive vaccines and medications are made available to our county as widely as possible to protect our community. Thank you very much again. All right, we have a motion, we have a second, and no further comments.
I don't have a motion or a second.
Oh, I'm sorry.
Does this conclude 5B as well?
Yes, that's correct.
Okay, a motion is also not required.
Okay, the motion,
Just
right, that's
FYI.
right, it's only information, sorry. Okay, all right, let's move on to item 6, thank you very much. Which is item report for the EMS, Emergency Medical Services Agency, relating to EMS system assessment and ambulance services request for proposals. And I believe we have our EMS director this morning, Nick Clay. Good morning, Chief.
Good morning, Chair Lee and Supervisor Abekoga. So before you today, we have our update on the EMS system assessment and the ambulance RFP. I want to first, just by acknowledging all the support we've received from our fire providers and ambulance provider regarding the submission of data All data analysis has been submitted, or data has been submitted for analysis and completed by our consultant. Additionally, AP Triton, our consultant, has met with all leadership from the fire departments as well as our provider ambulance service, County Ambulance American Medical Response, to provide feedback on our system. And now we're at the next step of the assessment, which is really the community engagement stake. So the goal there is to really cast a broad, wide net to ensure we have a collective review of all of our community. So there's 3 parts to that. First is a field provider survey, which will include partner agencies and providers at the field level. Next is our stakeholder survey, which includes folks such as yourself, city leadership, community advocacy groups. And then and we would value your input with that, as well as where we should target our attention for your constituents. And then last is really a broad community survey, which would be a website link in which any member of the community can provide their input. We expect these to be available here in the next several weeks. And when this will then complete the final information gathering session of the survey, at which point the AP Triton will provide ambulance delivery models for us to consider, as well as provide insights on the financial aspects of our system as requested by Supervisor Abecoga. We expect the draft to be initially available for the agency to review by the end of the year, and then publicly available sometime thereafter. With that, I'll pause in the assessment before we jump into the RFP side. Any questions, sir?
I don't have any right now. Do you have any, Vice Chair?
All right. And then lastly, on the ambulance RFP, our timeline remains very similar as we've discussed before. It must go to the state for review. That's set to be done sometime in July or June of 2026. From there, the state has about 6 months to review the RFP for release. And we would look to release the RFP to conduct that in early 2027 with contract negotiation, conclusion, and presentation by Q4 of 2027. From there, that gives us a 1-year ramp-up period to ensure that we have a truly competitive process, and if a new provider were to come in, they'd have time to set up their infrastructure, buy ambulances, et cetera, hire staff, and be ready to deploy services by January 1 of 2029. So we are in the early stages of development of the RFP, really looking at the structural elements, building the building blocks we can build prior to getting our EMS system assessment to look at what those delivery models might be. As discussed in previous meetings, the Chapter 1 regulations from the state are still in progress. We expect those to be released for public comment early 26 and then promulgated and actually effective early 27 at the same time we're releasing our RFP. We have been seeing deliberative drafts of those regulations, so we are prepared to match the regulations as we build the RFP. And with that, I will pause for any questions.
Thank you. Actually, I'll go and see if there's any public who would like to speak on this item, Jess.
Confirming we have no request to speak on item 6.
I'll give it 5 more seconds. I'm very surprised. I thought there would be a lot more public input on this one.
No one
Nope.
getting up in chambers? No hands going up on Zoom?
Thank you very much. We'll close that portion. Vice Chair, go ahead,
Great,
please.
thank you. Actually, I do have one question going back to the first part regarding the analysis. I saw in the report that you're asking for assistance in reaching out to community groups that should be included. And could you provide us a list of the groups that you have already engaged with, and then we can supplement? One group I noticed is the actual firefighters. So I guess you could probably go through the unions, but I think it would be very helpful to hear from them and to include them in the discussions in the survey. But if there's others, please let us know, and happy to help disseminate and encourage other groups to participate.
Excellent. We appreciate that guidance, Supervisor Abecoga. We will be reaching out to the fire unions and the firefighters through the provider side of the survey.
Great.
And then certainly we'll work with your board aides to find additional opportunities.
Thank you. And then regarding the RFP, a couple of questions. The current contract expires this December, is that right? And then there's 3 options.
Correct.
Are we guaranteed that the options are going to be executed?
I mean, the options are at the county's election, but yes, I think we are, they're unilateral options.
So they're not mutually agreed upon? We can just say we
That's
wanna-
correct.
Okay.
And
okay.
given the timeline that we've laid out, yes, we anticipate probably utilizing all of the options because even in the event of a new provider coming in, they'll have to be
Yes.
runway.
Sure.
So,
Okay, great. And then could you share in terms of your early discussions around the RFP framework, what some of the conversations have entailed?
So really, they've been, it's easy answer, they've been all internal. So it's really the framework and the structural building. The RFPs typically require a lot of, I would say, boilerplate language about timing and other things like that. So it's really building that infrastructure so that as we get the models delivery from the consultant, we can then incorporate that without minimal delay and ensuring we hit our timeline.
there's two things I would just add about the RFP structure. One thing that we know has to look very different than prior iterations is incorporation of a more stratified model. So the original and historic approach of the system has been ALS only, and without incorporation of BLS service into the actual design. Now, we're utilizing BLS service and have been for years, and a modern system needs to have that incorporated. So that's a structural change in whatever RFP happens. And then second is there's been some statutory requirements from the state that have changed, and one piece of that was the board adoption of certain components that the board actually took action on, I want to say in like 2023, that was in response to a bill from the legislature that are mandatory terms that have to be included. So those are two discrete pieces that are a piece of things, and then depending on, I think it's the next item on the agenda, how the nurse navigation program continues, that may be directly incorporated into a proposed RFP as well. I did want to add one thing about the state review. So Nick mentioned 6 months. That's the anticipated timeline, but the state doesn't actually have a deadline. And the state still hasn't promulgated its many years overdue regulation in this space. And that's a problem, and it's been a problem up and down the state in these processes for the last several years. So the state previously had specific guidance. There was a court case that forced the state to vacate the guidance because it was deemed an underground regulation, meaning it was acting like a regulation, but it hadn't gone through the process by the state to be a regulation. And so the state was then told, well, you need to now have a regulation, and they've still not done it. And I don't even remember now how many years it's been. It's been years.
Almost, I think 15.
Yeah, so so who knows what's going on with that or what's happening, but from my perspective, it is a deeply problematic position that it has put counties across California in, and it is one of the reasons why so many of these processes up and down the state have resulted in so much litigation, because that regulatory framework is just missing. But it's been an issue all up and down the state now.
Okay, great. And then in regards to the RFP, I'm learning a lot more about transport and how there are, very many different systems. You probably can guess my interest is that we cast the widest net we can. So I don't know if and I've heard in the past when you do these RFPs, they've talked about public and private. Now there's like hybrid, I hear, alliance models. So that would just be my interest, is that we make sure that we cast it as widely as possible so we get as many different options as we can.
Yeah, and that's been that. Yes, we want to make sure that we're casting a wide net as possible, but that is directly part of the issue that is happening up and down the state, which is there are these new models out there, but they're operating in this regulatory vacuum, and there's been a whole host of litigation. And it is challenging because of that. So, and a bunch of counties have now done a number of different things, and there have been hybrid models and alliance models and other public models and fire-based models, and there's now like half a dozen pending court cases. So it's, from my view, the state needs to actually do something here. Because this is one of those functions where we're wearing a hat as a regulator, acting on behalf of the state as a regulator.
Don't know what to regulate.
And the state hasn't done its piece, but then they're also not giving up control, right? So, it's one of these things where they want to approve everything. They got to approve the RFP. They're telling us, you're this thing, you're that thing. You can't do this, you can't do that. They haven't laid out the framework. They should they need to get in one lane or the other.
Right. Yeah.
Lay out the rules of the road, we'll follow them, or get out of our way and let counties experiment and do whatever we think is the right thing to do for our community. But this in-between that we've been in is really a problem for counties. It's not fair.
Well, I would like to request maybe that we engage IGR on this topic and
Yeah.
discuss it with some of our legislators to see if they can push.
Yeah, and
I think it's worth the conversation in light of the fact that we're, going through an RFP process. So it's very timely, and for what it's worth, I think it's worth at least bringing it up.
Oh, I agree with that, and I think we can put it on the list. It has been, just for your awareness, the subject of proposed legislation where the governor's office has basically stepped in and blocked legislative-based approaches. So the issue really resides on the administration side at the state with the state EMS agency. But absolutely, we can engage in that process.
And there's nothing that says we can't go talk to the governor's
Absolutely.
office,
No,
right?
100%.
He's part of the
100% agree.
IGR strategy. so.
Absolutely.
Thank you, Chair.
Thank you. My one question, Nick, is regarding the idea of conducting focus groups. Well, we've certainly seen so many stakeholders who have a lot to say about our EMS system, ambulance services, and RFP process, right? Which includes San Jose and other city fire departments, city management, police departments, hospitals, ambulance service providers, and of course our community members as well. Given all that, I don't necessarily think we might need to wait, but I think maybe we should just move forward doing the focus groups, since I think the stakeholder input is necessary. So is that doable?
Yes, we can work with our consultant to do those focus groups. They might be remote, just given our way our contract is structured with them, but we can certainly work on those focus groups.
Yeah, I think that's something we just move forward. I think will make a lot of sense, and certainly I'm sure we'll hear all kinds of ideas, but I think this is really a necessary step to move forward.
I will say that from my perspective, the individual feedback is really critical
exactly.
because we've done focus groups before, and certain voices tend to dominate, and then we hear on the side other people's opinions. So I think it has to be both pieces.
Absolutely, yeah. I don't think we should in any ways discriminate or exclude anybody on this process, yeah.
Absolutely.
Okay, good. And I think we really just want more information for this process, not less. And so beyond just surveys, I think we're able to use focus group to better inform the system assessment and subsequent ambulance service RFP. So that's all I have. All right, let's see. Do I have a motion?
A motion to receive the report?
And now I'm going to second that with all the comments included today. If no further comments, let's take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Great. Items 7 and 8 are going to be heard together. 7 is the annual report from the EMS agency relating to activities and achievements for calendar year 2024. And then item 8 is the quarterly report also relating to organizational activities and progress. And you're still Nick Lay. Hi.
I'm still here.
Go ahead.
So first and foremost, with regards to the EMS annual report, I want to start by expressing the agency's gratitude for the support of the Health and Hospital Committee, the full Board of Supervisors, as well as the Office of the County Executive. I want to acknowledge all of the EMS providers in the system who day in and day out are making sacrifices and providing the high level of quality care that we expect of them. And then certainly last but not least, I want to recognize the entire EMS agency team, who I hope through this report, their work is reflective of the work that they do every single day. Just a few key highlights that I'd like to draw out your attention to through the report. One is the demand of service increase. So from 23 to 24, we've had a 6% increase in service demand, but I would highlight that over the past 10 years, we've actually had a 20% growth in ambulance request, an EMS service request. So this growth requires us and our providers to be nimble and really be resilient as we balance the increased demand with a level of resource constraints, which is why programs like Nurse Navigator, which we'll talk about in just a moment, really do speak to the vitality of the system and address these increase in volume. And lastly, we can't talk about 2024 without mentioning Regional Medical Center. There's a saying that goes out that the obstacle on the path becomes the way forward. And we're presented with the challenge, we turn into that opportunity, and certainly an incredible amount of work was done by the county as a whole, and certainly by the health system to bring regional to bear. In terms of how that impacted our office, was the impact assessment, which is a comprehensive review of the impact of the closures and downgrade of service at the system. Then there was policy changes made and work by all of our providers as well as our partner hospitals to balance that patient load with regional's closure or downgraded service, and then quickly pivoting from that to the incorporation of regional into the health system and rebalancing and making sure that we applied the same rigor to the specialty care designation process as well. So I just wanted to highlight those things for you within the report. Moving on to item 8 in our quarterly report. Two things that we'd like to highlight. First, we want to start by talking about Marvelous, which is a system support tool. So we have our computer-aided dispatch system, and then we have this sort of overlay system that helps move ambulances around the county and interact with the CAD. I want to start by thanking CEO Williams for his support and engagement on this issue, and then recognize the engagement of the leadership at the County Communications Center. It's a significant effort to add this program to the Hexagon CAD, and they have been nothing short of just incredible to work with, as well as County Ambulance. AMR has been a great partner in launching this program. We actually had a meeting yesterday in which we expect to deploy the balance of the Marvelous system on early November. And with that, we'll have a variety of additional additions to the CAD system. One will be ambulance movement. We hope to be more efficient, actually increase the level of ambulance availability within the county. Secondarily, will be unit recommendations. As Executive Williams mentioned, this sort of tiered system of BLS and ALS ambulances, or basic life support and advanced life support. Marvelous allows us to have a much more nuanced approach to how we deploy those resources, so it would be a significant improvement in service there. And lastly is access to data. We'll have a tremendously more robust set of data feeds and reports we can run with Marvelous. With that, shifting to Nurse Navigator. So Nurse Navigator, we ran the pilot, began November 13th of last year. And again, just want to acknowledge those who participated in our pilot program. So our county fire department participated, Morgan Hill Fire, Cal Fire Department participated, Gilroy Fire, County Communications, and AMR were all a significant part of the process. And I just want to make sure that we reframe sort of what that pilot intent was. It wasn't necessarily to revalidate the Nurse Navigator program was a viable program. It's nationwide. They respond to 50,000 calls a year. The intent of the pilot was really to figure out how do we maximize the deployment within the county, how do we adjust policies and integrate within our existing system. And that's what that pilot provided. And now we feel like we're in a good position to deploy that program. I would say that just to sort of remind Nurse Navigator sort of what it is and how it can impact our community, especially with the Margolin report and the impacts that we're facing to healthcare nationwide, specifically in the country or the county. The moment a 911 call is answered, the dispatcher goes through to determine the acuity of that patient and the resources required. Low acuity patients are then offered the opportunity at the County Communications Center to speak to a nurse. That nurse asks another series of questions, and at any point in time, that patient can always be referred back to the 911 system should that patient acuity change during the course of the call. Then once that nurse goes through the series of questions, they then are able to offer at-home care, advice, a ride share to a pharmacy or a clinic, or non-emergency transport to the emergency department. The total time on task for this from the moment the 911 call is answered to the nurse navigation disposition is about 10 minutes. So it's a really quick process. And then all this happens at no cost. The county pays nothing for this service, the cities pay nothing for this service, the providers pay nothing for this service, and most importantly, the patient doesn't pay for this service. And it really saves the patient time, it saves the patient healthcare costs and potentially medical bankruptcy. And also increases the availability of emergency resources for emergency calls and takes those low acuity patients and provides them a better access to care. In terms of the pilot, there absolutely were some challenges, as you would expect in any launch of any program. We did have some early adopter apprehension as not only the patient side, but as well as our provider side. If you think about what EMS has done for, frankly, hundreds of years from Civil War, where you're putting people in the back of a buggy and transporting them to the physician, to now where we have, bringing the sort of mini hospital, if you will, to a patient. But the only option has only ever been take the patient to the hospital. And that's how our providers have always operated, and it's what the community expects of us. So there has been some apprehension in terms of shifting from a model and where I called 911, my expectations to go to the hospital. We're now saying, you called 911, now you have a variety of healthcare options at your disposal to put you in the right place at the right time. Our volume, as a result, was low, only 166 calls. If we look at the area in which we did this pilot program, it's only about 1% of those calls. So again, the intent wasn't to sort of say, is the volume the tipping scale or is the system functional? It's really how do we employ this system? And through that, though, we were able to identify those challenges. I will say, though, using an estimate of average healthcare costs in the Bay Area as well as average ambulance costs to the patient, just that 1% of calls is about $750,000 in healthcare costs to the patients that were served. And once fully implemented across the county, if we look at every dispatch center having this program and every provider offering this in the field, even if we maintain a 1% success rate with Nurse Navigator, that's an estimation of $7 million of healthcare cost reduction to the community. So what happens next? How do we make this program even more successful and proliferated across the county? Centralized training. One of the lessons learned is that we had training done by a variety of different providers with varying different information. We've brought all of that information centralized at the EMS agency and deployed that over the next several weeks. Providers will be trained on how to do this more effectively. We've identified some serious gaps in data and how do we navigate data collection to really target where the challenges are and how do we, again, maximize the program. AMR is in the process of expanding all of the urgent care and clinic network they have, so it's been focused in the pilot area. Now we need to expand that clinic access across the county. And then as of January 1st, all providers will be able to provide field referrals, so the 911 calls occurred, providers have been dispatched to the call, and now based on certain conditions for low acuity patients, they can, at the scene, offer Nurse Navigator across the county. The long-term plan, of course, is to get this in every EMD center across the county so that at the moment of dispatch, we can save those resources for the next available call. I would just highlight that really now is the time. As we heard, there's a significant impact to Medicaid recipients. A quarter of the county is covered by Medicaid, and as we look at reduction of access to health care in a situation where we can expand health care to the community for free and really provide them the necessary tools and access to gaining access to health care at a moment when 911 is routinely used as they have nowhere else to go, so they call 3 numbers, and medical professionals are there in a matter of minutes. That's only going to grow in the impact, and if we wait until we see the impact of the increased call demand with less access to health care, it will be too late to sort of really proliferate this program. So we're excited to keep on going, and we're excited for your support as we expand this across the cities and different dispatch centers. With that, I will conclude our report and happy to answer any questions on both item 7 and item 8.
Thank you very much, Nick. Let's see, anybody would like to speak on item 7 or 8?
Quick pause. I don't see any requests to speak either in chambers or on Zoom. Again, this is 7 and 8 together.
Okay, yes, Vice Chair.
Thank you, Chair. Thank you for the presentations. A few questions. So I was reading the annual report, and I think it's page 8 that has the little visual. I'm good at better at visuals, but I noticed that it was about the increase in calls and I guess just in general, you mentioned the increase in calls, 6% in a year and 20% over the last 15 years. Is it, what would you say is the reason for or there might be many reasons for the increase, but some of the reasons?
Yeah, certainly. I think it sort of tracks the national and state trend of increase in demand for EMS services. Certainly as population growth occurs. As populations age, we tend to see an increase with that. A recent report out of San Francisco Chronicle showed that the Bay Area does have an increase in population over 65, which would also track with this. And then I think just access to healthcare. I mean, if you think about where the world is moving and what we've experienced, certainly folks call 911 because they have nowhere else to go. They don't know who else to call. So I think it sort of tracks all of those.
Okay, yeah.
I would just add, I do think age is a significant factor, as Nick mentioned. The other thing is there was a significant increase post-COVID, just nationally, but also locally, and just in healthcare in general, system-wide impacts that have not abated, meaning that there's been now for several years a sustained higher level of activity and call volume.
I was wondering if are people getting sicker, or is it that there's more awareness, to just calling 911, or both? Yeah.
Yeah, I don't know if that it's people necessarily getting sicker. Maybe it's just more awareness and familiarity and comfort with utilizing medical care that comes out of kind of just people's experience through COVID.
So, I'm sorry, going back to the graph, it's page 7 in the report, I believe. It's the stats, EMS system stats. So it says 143,000 requests for ambulance service, 100,000 actual ambulance transport. So is that difference, the 43,000, are those the calls that we're trying to divert to Nurse Navigator or through Nurse Navigator in other ways, or?
Yeah, absolutely. So even just the response time of that unit not being available, we want to reclaim that unit time so that unit's available for the emergency. There's so many reasons why we have that non-transport rate. Folks call 911, providers arrive, now they feel reassured that they're healthy, so they don't necessarily want to transport to the hospital. And also the low number of EMS dispatch determinants that are assigned to the call. We do have a high volume of calls that are not triaged. So with that lack of triage, we don't know what we're responding to, so the safest thing is to then send that resource to the call. They get to the call, might be a fight in progress with no patients, and that call is then released. So those combination of factors certainly increase that percentage.
And this is where you may be aware, we've had some specific challenges with the San Jose Dispatch Center over EMD. Their rate of EMD is around 2/3 of calls that are actually being triaged. And the non-triaged calls are automatically getting a code 3 response because we don't know. So they're getting a code 3 response, they're getting the highest level of service, but we have no idea. And so a chunk of those calls, certainly there's a portion that may have merited that, but there's a large portion that would not have.
We just don't know.
And we don't know, and so they're going code 3, and that's a piece of it too.
Okay, thank you. And then regarding Nurse Navigator, it mentions that some of the other EMDs have yet to adopt it. Even there's 4 fire departments here. I was wondering, the other 3, I think I know, Milpitas, Gilroy, Morgan Hill, are they already on board, or what's the status with them?
Certainly. So Supervisor Abikoga, Morgan Hill and Gilroy are part of the program as their EMD is
they're
done by the
south.
County Communications
Okay.
Center.
Okay,
And
great.
Milpitas, while their EMD is done by the County Communications Center, they are not participating in the program. So
And
San Jose, Mountain View, and Palo Alto Fire would be the other dispatch centers that we would look to incorporate in this program. And there's a lot of hesitation, unknowns. I think there's a fear it's a reduction of service as folks are used to calling 911 and getting that response, and now they're going to actually get a different set of expectations and tools. It's caused a lot of challenges in the pathway of getting there. And then certainly we're dealing with a mixture of law enforcement dispatch centers, fire dispatch centers, and, and through growth there. So we would love to proliferate the program further. Just dealing with some of those challenges has been slowing it down.
I will say San Jose is critical because it's the largest center in the county and probably candidly has the most calls that not only obviously has the most calls, but I mean the most calls that are likely to be impacted by the program. And so that's, that's where we'd love to see this implemented. I know there has been past support and interest from the city manager's office in supporting the program. I think there have been some concerns from the fire department, but I don't think we'll really see any system-wide benefits in terms of actual ambulance resource availability until and unless San Jose implements the program.
And then Santa Clara City, I know they're
Oh,
not a
sorry.
part of the mutual aid. Is that why they're not on here too, or?
Sorry, so Santa Clara City also is a center we'd like to get Nurse Navigator in, but they chose not to
Okay.
participate in the Nurse Navigator pilot.
Okay, great, thank you. And then appreciate the CAD system upgrade. You noted some challenges with the transition to the new system. And we're looking at November 2025 to go live, is that right?
Correct.
What were some of the issues that were encountered in the transition that we can learn from to avoid when we relaunch?
Certainly. So when the Hexagon is the program we switched to for the
Yes.
new CAD in September of 2023, with that, they provided a product called Live MUM, Move Up Module, I believe is what the MUM stands for. And essentially, it's a dynamic tool that operates in a similar capacity to Marvelous, but the algorithm technology is much, much different. And the biggest challenge with that program is actually it would show a unit as covering an area while it was en route to that area. So it could be coming from Cupertino and moving to Milpitas, and it would show Milpitas is covered. However, that unit's somewhere on 280 navigating through traffic to get to Milpitas. So we had quite a bit of challenges in actually putting ambulances in the right places with that program, as well as sort of ambulances doing a merry-go-round of round robin versus more efficiently moving through the county. So we think with Marvelous, we've used in the past, it's a known product, and because we can really control how those units move, we expect to see a much greater ambulance availability as a result.
Okay, great. Thank you.
Yeah.
Thank you so much. Thank you, Chair.
Thank you. I have a couple of questions. So the long and short of it looks like we're going back to Marvelous, basically.
Correct.
That's the takeaway I got from that whole reading. One. Second is regarding Nurse Navigator. Just want to confirm the numbers. You mentioned the 1% diversion saved us. I thought I heard 7 million, but the report I think says 700,000 for the 1%.
Yeah, so it's
right?
754,
It's
all based
754.
on estimates based
Right.
on local data from Kaiser Foundation as well as average ambulance patient charge.
Right, but the goal is that we might actually be able to divert, say, at least 10%. So
Correct.
then that would become 7 million or potentially more.
Well, 7 million is just if we keep the 1% number for every call in the county, we could end up with 7 million. We could go, if we end up with a 10% reduction, I think the number is about $46 million of estimated savings in healthcare costs. Again, so many different factors, but certainly a ballpark to target.
Okay, good. Yeah, no, I just want to make sure I understand that. Thank you. The CAT system, I think it's all these, I think, would aim toward providing the right resource to the right situation.
Correct.
And when you dispatch a proper resource, or in some cases not over-resource, to a minor situation, it would not only save us resource or cost, but saves us time for those who really need that resource. So in terms of ambulance wait time and whatnot, especially the more critical cases, this should reduce those wait times. Is that a correct statement?
Absolutely, we expect putting the right resource, not every tool, to get the right tool, a hammer isn't the right tool for every project. So we think that there is absolutely going to be an increase to ambulance availability as a result of this.
Great, thank you. No, so thanks for the report. That's great news. And I've got a motion
Yes, happy to make a motion to receive the reports for 7
and 8.
and 8.
Yes, and I'll go and second that as well.
Thank you.
All right, let's go take a vote. Jess?
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well. Thank you
Thank
very
you.
much, Nick.
Thank you.
All right, moving on to number 9, which is a Public Health Department report relating to Asian and Pacific Islander aggregated data. And we've got Dr. Redmond.
Thank you so
Hello.
much. Well, it is my pleasure to introduce Dr. Wayne Eninoria, who is our Chief Science Officer and really the architect, along with Dr. Cody, of our entire science branch, which leads the vast majority of work coming out of our department that has to do with understanding data, science, making sure we have access to what we need. So I'm pleased to hand over to him to offer a short presentation this morning, and then we'll be happy to answer your questions.
Thank you, Dr. Redmond. Good morning, Chairperson and Vice Chairperson. It gives me great pleasure to be able to present to you the 2025 Asian and Pacific Islander Data Disaggregation Data Report. Next slide. So the purpose of this report is to really summarize data, health data, disaggregated. As you know, most of the time, Asians are lumped in as one big group. And the purpose of this is really to share some of the data, what happens and what can we learn when we disaggregate the data by different Asian subgroups and present that data, as well as talk through a little bit of some of the challenges we have with collecting Asian subgroup information, as well as what we're doing about some of the data gaps. Next slide. So as you know, when we talk about Asian as a whole, the Asian race category represents over 20 countries of origin with distinct cultural, socioeconomic, and immigration histories. So this graphic really just displays some of the countries that we're talking about here. East Asia is denoted in yellow, South Asia in green, and Southeast Asia in red. So as a whole, if we describe health and health disparities with respect to Asian as a large category, we tend to mask some of the nuances as well as the differences in health across these different categories. Next slide. So PhD, as you know, as a local health department, we are part of a larger public health system. We do try to collect as much information on race ethnicity as we can. Our information comes through various sources that are reported to the health department. We actually do collect some special survey information as well, particularly through the California Health Interview Survey. We also do rely a lot in terms of Asian subgroups on U.S. Census Bureau data, particularly around social determinants of health. And as you know, we collect a lot of information regarding public health surveillance data using many of our state systems, as well as other systems. And I'll talk a little bit more about that later in this report. Next slide. So nearly 40% of Santa Clara County residents identify as Asian, according to the American Community Survey. I have the citation there at the bottom of the slide. When we break down Asian as a whole, as a group, into its component subgroups, we note that Chinese and Asian Indians represent the largest Asian subgroups within the county. Chinese, 30%, Asian Indian, 26%, and you can see the various other proportions in this pie chart here. Next slide. In terms of overall median age among all Asians, it's 37.6 years. Japanese have the highest median age with 51.4 years, followed by Filipinos and Vietnamese with about 43 years. When we look at overall education among the different Asian subgroups, we note that there's a huge disparity between the different subgroups. Vietnamese having the lowest, percentage of the population who hold a bachelor's degree with 32.8%, while Asian Indians have the highest with 90.6%. So there is a huge disparity across the different Asian subgroups with respect to education. And here I'm talking specifically about what percentage of the subgroups have obtained a bachelor's degree or higher. Next slide. When we look at overall household income, another social determinant of health, we note that the Vietnamese subgroup has a very low or lower median household income with about 101,000 versus Asian Indian with approximately 208 median household income. So again, across the Asian subgroups, we can see a huge disparity with respect to median household income. Next slide. When we shift over to health outcomes like all-cause mortality, so death due to all causes, we can see that all-cause mortality is the highest among Vietnamese and Filipino residents within the county. You can see the dark green and the lighter green bars there. And then you can see how they shake out, or at least how the deaths per 100,000 population look for some of the other subcategories. Again, huge disparities in all-cause mortality. As we shift over to, next slide, cause-specific, or at least another way of looking at mortality is looking at life expectancy. we see that Chinese residents, on average, have a life expectancy that's 7 years longer than Filipino and Vietnamese residents. Again, this is looking at data from 2020 through 2024. So life expectancy also is, varies across the different subgroups. As we move towards looking at cause-specific mortality, next slide, for death rates due to overdose among the different Asian subgroups, we see that Vietnamese, Filipino, and Korean residents overall have higher death rates due to overdoses than some of the others. You'll note here Chinese and Japanese subgroup data are not shown, and that's because the numbers for overdose deaths among these groups are very small, so the calculation of the rates ends up becoming very unstable. So we don't actually show those rates on this slide because we don't have any confidence in those rates. However, we did want to show you the rates that we do have and that we do feel fairly confident as far as the rate, the death rate due to overdose for the other Asian subgroups. Next slide. Now we're shifting over to death rates due to COVID-19. Again, this is for the period 2020 through 2024. We can see that Filipino and Vietnamese have a very high death rate due to COVID-19 as in comparison with the other Asian subgroups listed on this slide. Filipino having 47.3 deaths per 100,000 population, and Vietnamese having 37.2 deaths per 100,000 people. Next slide. So again, public health being us as a local health department, being part of a larger public health system, we receive data across many data sources transmitted and sent to us in many different ways related to public health surveillance. Most notably are reportable disease and conditions that are mandated under Title 17 California Code of Regulations. We also receive a lot of extensive immunization data across the state for our residents, as well as birth and death certificate data. So there's lots of information that come to us. I think the challenges with collecting Asian subgroup information is that we are part of this larger state public health system. So any changes in data collection and standardization across local health jurisdictions in California will take state effort and state conversations to have. We do, again, try to collect whatever information we do collect and get to us to be able to summarize that information. But it's oftentimes missing, oftentimes incomplete through things like electronic lab reports, confidential morbidity reports, and other mechanisms that and ways that we collect information. Next slide. But we are using all of our ability to try to collect extensive information. I just shared with you just a snippet of what we can learn when we disaggregate Asian as a whole group and display and show health information regarding different subgroups of the Asian groups within the Asian groups. But we are working with the Office of the County Executive to try to understand how data, particularly around race, ethnicity, are collected throughout the county and try to make recommendations, try to understand truly how we can move towards standardization. We learned an incredible amount from our Latino health assessment, particularly the service utilization section of the Latino health assessment, in terms of different county agencies and how they collect race and ethnicity across their county programs and agencies. Again, they are also too beholden to their federal and state guidelines and regulations in terms of what data they collect and how they actually collect it. So again, the issue of standardization is not an easy one. But we have certainly opened the conversation as to what we want to be able to collect to understand, for us, particularly population health and health disparities. We are also considering the intersectionality of health with all social determinants of health and other personal demographics, including race, ethnicity, for things like disabilities that we know are incredibly important for us to understand when we think about health and what shapes health and influences health. So we are looking into that as well. And again, I think our Latino health assessment work is definitely putting us and engaging communities for us to be able to solicit their impact, or at least their influence and feedback on how they want to collect information, what information they think is useful for understanding population health as well. Next slide. So we do have supplemental analyses, that is additional slides that we include in your packet for you to get, again, more information on Asian subgroups that I didn't necessarily go to or cover today. But with that, I'm happy to answer any questions.
Well, first of all, thank you very much for these very illuminating charts. Certainly, a lot of things we kind of expected, but certainly quite a few things that's also surprised us as well.
Yes.
Before we ask questions, do we have any public comments on this, Jess?
Seeing no requests in chambers, no requests on Zoom for item 9.
Thank you very much. Yes, Vice Chair, do you have any questions?
Thank you, Chair, and thank you so much for the very interesting presentation with all the data. I read the report, but it's always helpful. I'm, again, visually better, so I appreciate all the charts. So certainly, this is of interest, given our growing API population here. As we've talked about, the aggregated data may look like our community is doing pretty well, but when you disaggregate it, we clearly see the stark differences, and that certain communities are more challenged. And I know that the county's done a great job with like Hep B prevention work, the community health worker program, and that's really was one of my concerns, is that the CHW program, I believe, is funded through the end of this year, but there's uncertainty after that.
Yes.
And so that was my first question is, how does the Public Health Department plan to work with ACI? I believe that is the organization that administered the program, to be able to preserve some sort of version of the program, since it seems to have been quite successful. And I think the overall question is, we did the assessment, I believe, in 2018, and there definitely recommendations, the health worker program being one of them. And how do we keep it going? And then when do we do another assessment? Is this something that we should be looking at doing, with census after census? Like, I don't want this to just stop, because it happened once, and especially with the CHW program, the work needs to continue. My goal would be, I think we all want these numbers to go down. So how do we keep it going in light of, I know, the challenges we have with the budget and whatnot?
Yeah, if I may, I'll step in, and thank you for the question, and for this referral, because I think it really gave the department an opportunity to collate some of the amazing assessments already happening. I think to your first question about the community health worker project, I know that we're due to report back to you on how that progress is going, helping ACI obtain separate funding to continue what they're doing, as well as the work public health continues to do to support them in kind to the extent we can without that allocated funding, through things like capacity building, resources, convenings to help train community health workers and to help them recruit their community health workers. But I agree with you. I think, this is one of several instances where there's work we know needs to continue, but we're also in an environment of such constrained resources that often we are looking for ways to support our community partners in continuing it with diminishing resources. One piece to your question about sort of when is it time for additional community assessments, I think this is something, especially with the advent of the science branch, we've been grappling with, because one thing we may not be doing well as a public health department is highlighting how many specific assessments are ongoing in real time. Some of these we bring to HHC. For example, I know we bring our a sexual health update annually, which really highlights what we're seeing across all races and ethnicities and other subsections and identities with respect to sexual health. Or we bring presentations specific to overdoses. And similar to that, all across the department in the specific areas of work, sort of grouped by often disease outcome or activity we're doing to prevent a certain type of disease, such as nutrition focus or physical safety focus. We are constantly disaggregating by race and ethnicity, as well as other factors, to say, are we making progress in general, and then are we making inequitable progress, and we need to focus on a particular population. And in that work, we often try to disaggregate by Asian subgroup to make sure we're asking that question in the most refined way, and then figuring out, are there more specific things we need to do? So those types of analyses, especially looking across races, ethnicities, subgroups, is happening in real time all the time. But to do it in the comprehensive way, like we've just done with the Latino Health Assessment, is an additional huge resource allocation necessary to do that well, and to make sure that the community input is brought in to help us ask the right questions and interpret the data correctly. So the question about when it's time to do another race or ethnicity focused assessment is a complex one that often takes into account what we're hearing from the community, what we are knowing is changing about the environment, and what we are realistically resourced to do in a particular moment. But knowing that there are also signals we're getting in real time to help us correct course without a large community-wide assessment, so that we don't take our eye off the ball in between assessments.
So in light of the fact that we've done this assessment and I think we can now pinpoint where to focus, I would expect that if we were to do it again, it can be streamlined somewhat. I guess you still want to make sure you do an overview because there could be changes in other populations, but I would expect that we could just continue to build upon the first assessment as we do future.
In general, yes, absolutely. And I think, again, every assessment we do, even for different races and ethnicities, or our support for the county's LGBTQ assessment, for example, we learn how to do better. And so the recent experience with Latino Health Assessment, for example, was the first time we ever did the added layer of looking at county service delivery. And so we've now learned how to do that. Again, still resource intensive, not just on our part, but on our colleagues across the county. But we do have ways to do it slightly more efficiently now. But I do see a major priority, both from this initial look at disaggregated API subgroups and from the Latino Health Assessment, have both concluded we need to do a more robust job in just being complete in our gathering of race and ethnicity data, being robust, and where those systems are outside of our control, advocating for the state level changes that we need to see.
Great, thank you. So going back to the CHW program, as you can tell, I'm very concerned about it ending, and I don't know where this fits in. And I very much understand, the budget challenges we have, but is it a budget item that we should be looking at? And of course, it's going to be looking at all of the items and juggling and whatnot, but as you've probably, you've heard me say, I would rather continue programs we have that are working well and progressing rather than starting new programs, for instance. So where can we bring this up to find ways to continue it in some form?
Yeah, I do think it would be a budget discussion. My understanding is it was funded on a one-time basis a few years back, and so there wasn't ongoing funding provided for it. And so that would need to be identified, and in the context of the current budget, basically is something else as an offsetting reduction. But it would be the budget process that would be the appropriate place.
I don't know, Chair, and I know there's a Brand Act issue, but is that a conversation we could have at some point
Sure.
at the committee?
Oh, absolutely, yeah.
Great.
No, I
Thank
think
you.
it's, yeah, thank you. And no, I think it's very enlightening. First of all, I think this really proves one very important point, that this is really irrefutable, that desegregation of information, of these data, especially in this case for specific for the Asian population, but even for other types of segregation, is absolutely crucial for us to figure out where the need is. And in this case, let's say between the Vietnamese and the Filipino communities, those two certainly has far more challenges on health impact and and you know, age and whatnot. So I think this is something that we need to continue. And of course, the resources needs to go to the community that has the most need. That's very clear. And one thing I do want to ask is, I know there's a lot of pushback with federal administration on so many things, and I believe the segregation of data is also one of them. Do you think we might be able to get more out of this with the state, potentially, to work on getting more assistance from the state to do more of this type of work and funding and whatnot?
Well, I think some of the complexity there that you alluded to is that whatever we in the state are doing is in the context of a federal government that is pulling down existing data sets, removing race, ethnicity, certain genders from existing data sets. So we do have a headwind in whatever we are doing, as well as thinking really carefully about as we always do, protecting the privacy of our residents and anyone's data that we are gathering, and making very sure that we know exactly where those data go, the technical supports to make sure those data go nowhere they're ever not intended to, and understand who has access to them. So in that context, my sense is that we do have a great deal of support from the California Department of Public Health to continually improve our data collection systems, but often beyond building simply the technological systems we need that ask the right questions and allow the right data to be gathered. We need the folks who generate those data to have the resources and ability and knowledge to prioritize collecting them. So we need everyone filling out a birth or death certificate to actually ask a family how they identify, as opposed to make an assumption about it. We need, many of our disease data come via laboratories that sometimes don't have systems feeding into them that include race and ethnicity data. So even if the order for a particular lab test that turns out to lead to a report to us has the ability to capture race and ethnicity data, those data may not go to the lab and therefore never make their way to us. So yes, I think in short, you're correct that we will certainly make much more headway having this conversation with our state partners than our federal, because we're seeing movement in the wrong direction at the federal level. But I also see our state partners already agreeing with this level of improvement as a goal, but struggling and running up against lack of resources to achieve it fully.
Good, thank you. On the chart, I recall seeing something that used to be collected, but I'm trying to see if we could also demonstrate that now. There's a chart here on the packet, page 60, which shows the death rate from COVID of the different demographics. But I also remember there used to be one that shows the vaccination rates of those with this similar breakdown.
Yes.
And I would like to put those two together. I think it would be very instructive, number one. Number two is, if I vaguely remember, Vietnamese community, for example, was actually one of the highest community that were vaccinated for COVID because of various reasons. When they came as boat people, that there's a huge trust on public health
Yes.
on that work. So I think those are information I think could be helpful to overlay on this as well.
Slide 24 and 25 in the supplemental actually shows the percentage, slide 24, percentage of completed COVID-19 vaccine series was highest among Asians in comparison to other race ethnicities. And then slide 25 shows percentage of completed COVID-19 vaccine series among the different Asian subgroups. And you'll see there that
Okay, here we go.
it was lowest among Filipino residents compared to other
Right.
Asian.
Right, yeah, so
residents.
Vietnamese is definitely the highest. Thank you so much for pointing out. I missed this one. But then Filipino, in this case, the lowest in terms of vaccination rates, but also the highest in terms of the death rates.
Yes.
as well. So I think that actually correlates and that makes sense. But as far as Vietnamese is concerned, if they are the highest rate of vaccination, but they're still the second highest on death rates, that would, I guess, indicate that other factors. right,
Correct.
would
Yes.
be
Again, these
the-
are population level
Yeah, exactly.
outcomes.
Right.
There's many things that could play into that.
Sure,
That are
absolutely.
not necessarily captured here.
Right. I mean, we certainly should not say something like, gee, look, if you eat Chinese food, then you have the longest life expectancy. That would be the type of correlation, right, that somebody could draw, which we know is not true.
Yes.
And that's why the causation versus correlation is very important.
Yes.
Right? Exactly. All right. Good. All right. Let's see. Okay, one more thing. The report also states that the public health is working with the CEO's office on recommendation for collecting the detailed demographics data across the county entities with intention of standardizing the data collection methodologies. Is there any idea when this would be provided to us in the future?
Yeah, we're working on a policy. I do think it's really important to note what we are and aren't talking about. The overwhelming majority of data that the county collects is in state and federal related data systems where we don't have discretion to add data fields. So take, for example, the social services context. It's all state data systems. So what we're really talking about is that small subset of data that is purely locally collected and administered, where we have discretion to make sure that we're including additional data fields and not where we're just uploading information into state systems. So we're working on that, and it's inclusive of SOGI data as well. So it's the two biggest areas being addressed are gender expression identity and Asian subgroup data. But I don't want people to get overexcited, because I think most of what people want to see in those areas are really data systems that are not under our control. So, but yes, we're working on that for county level data. And I'll give you one concrete example. We have changed our own workforce data gathering for county employees in our HR system to include Asian subgroup data and gender expression identity data. So that was a change that was made just in the last 2 years.
Great. No, thank you very much. That was very helpful. Let's see. We have a motion?
Yes, I'll make a motion to receive the report.
Great, and I'll go ahead and second that, and looking forward to getting these report back in the future. And thank you for this really, really helpful data collection, and this is certainly something that we have more work to do, but this help guide us where we need to go next. Thank you very, very much.
Thank you.
Thank you. All right, moved and seconded. Let's take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Okay, 10, 11, 12 has been dealt with under consent, so we're back to 13 now, which is the recommendations relating to federal and state health policy and budget landscape. CEO. Hi, Paul.
Thank you, Chair Lee, Supervisor Abe-Koga. Just a few updates for the health system. So I'm very pleased to report that, as you well know, we utilize Epic, which is our electronic health system. Epic, who is our sponsor and supports our electronic health record system, named Santa Clara Valley Healthcare to its honor roll with a cum laude distinction. And what that means is that we are the only health system in California recognized at this level in terms of our system. So it shows that we are the top performing health system worldwide for the advanced use of electronic health record technology to improve patient outcomes and care experience. So that's quite the acknowledgement from Epic, which is worldwide.
Worldwide, wow.
We've also been recognized by Cal Hospital Compare, 3 hospitals, O'Connor, St. Louis, and Valley Medical Center, for leading substance abuse, use disorder honor roll. So we were placed on the honor roll, and that once again just shows our sustained effort in supporting individuals that are dealing with substance use disorders. So that honor roll is a distinction that we're very proud of. And as you well know, just recently, we did, on August 28th, launch our Compass Clinic in partnership with the Behavioral Health Department, which provides safe and compassionate and an interdisciplinary approach to substance use recovery. So we're very proud of that work in that area. Moving on to just general operational updates for the health system. We are entering respiratory season, and so we fully expect that all hospitals will continue to be busy. A regional medical center continues to outperform where we had expected it to be, both in terms of volume, but also in financial performance. So I'm just very pleased with the progress that we've made to date. At Regional Medical Center, I do want to be sure everyone understands that on October 20th, we'll be launching the labor and delivery service and NICU services at Regional, and we will have an event on October 16th to celebrate this important service for that community and, frankly, the residents of all of Santa Clara County.
Mm-hmm.
So that is my report.
Good. Thank you very much, Paul. No questions? Yes. Move down. Go ahead, Dr. Whitman.
Well, I do have, just alluding to the very confusing messages coming from the federal government over the last week, want to just display a couple of visuals to make sure everyone is very clear about this respiratory virus season and where we are with access to vaccines. So after, and actually just prior to when the ACIP met last week, that is the committee of the CDC or supported by the CDC that is meant to give evidence-based guidance on vaccines. The state of California took action as part of a budget trailer bill to make sure that should the ACIP give unscientific recommendations, we were prepared to make sure Californians still had access to vaccines. And that is exactly what happened. So fortunately, because of this trailer bill language, even though the ACIP ultimately voted to change some of the language around who was allowed access to COVID vaccines, in California, anyone 6 months and older is able to get the updated vaccine this season. I'm going to say that one more time. Anyone 6 months and older who would like to get vaccinated in California may do so this season. And the way that the bill was crafted, it also requires all insurances that are regulated by the state of California to cover COVID vaccine for anyone 6 months and older who wants it. So if you are insured, whether you have Medi-Cal or private insurance in California, your insurance should cover that cost as well. And Santa Clara County has independently reviewed the recommendations from the California Department of Public Health that is based on scientific evidence by experts and expert organizations, and so concurs with these recommendations coming from the California Department of Public Health. And we have these updated guidances posted on our own website below, as well as the California Department of Public Health is posting their guidance, and they are part of a West Coast Health Alliance with the governors of Washington, Oregon, and Hawaii that are all in alignment about these recommendations. There are specific groups who are especially recommended to get COVID vaccine this season, and so I do just want to highlight those. For those who fall outside of those in the blue category, anyone who wishes to is still welcome to, and for really the vast majority of people, the benefits far outweigh any risk. But it's especially important for babies ages 6 months to 23 months to get vaccinated, for those ages 2 to 18 years old who have risk factors, for anyone who is in close contact with folks with risk factors. So that may involve a family member with a young child or an older adult. That may include a healthcare worker. Anyone who is pregnant, postpartum, lactating, or planning pregnancy, especially important to get vaccinated. That not only protects the pregnant person during a period they are highly vulnerable to serious disease from COVID, but also offers protection to the baby after birth. And then adults, especially those 65 and older, really have some of the greatest benefit of getting vaccinated because they have the greatest risk of serious outcome if they are not and get COVID, as well as those with their own health conditions and anyone who is in close contact with those with high risk. For flu vaccines, as in previous seasons, everyone 6 months and older is recommended to be vaccinated. And again, especially those who are pregnant. And then for RSV, the third disease we often see cause some of the most harm and sometimes death in the winter season. There are new vaccines and protective shots that have come out just in the last 2 years that are recommended only for a subset of the population. Those who are pregnant, and that's primarily to protect the infant after birth. Those infants whose parent was not vaccinated during pregnancy, and those 75 years and older, as well as those 50 to 74 with certain health conditions. And so the last piece I want folks to be aware of is that because there has been so much confusion this season about what would be available, what would be recommended, what would be covered, the access issue is a little bit delayed compared to past seasons, but rapidly improving. So I'm proud to know that our own Santa Clara Valley healthcare system is up and running with vaccines for those 12 and older, although we understand that the supply, we need a slightly different type of shot for those 6 months to 12 years, and that supply has been late to come in everywhere, including to our own system. But I'll defer to Mr. Lorenz if he has anything to add, but my understanding is they're very close to being ready with those pediatric vaccines as soon as that supply is here. We're hearing similar things from our other organizations such as Stanford, Sutter, Kaiser. Some are completely up and running with pediatric. All are up and running with older children and adults, and some are still waiting on pediatric vaccine supply, but expect to be ready to go very soon, possibly as early as next week. And then, fortunately, because of the trailer bill language that passed last week, pharmacists all over the state are also able to give vaccines exactly the same way they could last year. So regardless of your insurance, regardless of which category you fall into, if you are eligible for any of these vaccines, a pharmacist should be able to give it to you, whether in our own pharmacies or a retail pharmacy like CVS or Walgreens. But the best place to figure out what applies to you and what you need to know about it is to still go to the My Turn vaccine locator. And we have the URL here for folks to go find where they can get the vaccines they need this season. And the public health department, especially after next week and the week after, when that supply has landed more consistently everywhere, will begin pushing out messages to our community to make sure folks know it's time to go get your winter shots and make sure you and your family are protected. That's it for my health officer report today, but happy to take any questions.
Thank you, Dr. Rahman. I just have a quick question on the My Vaccine Locator. Is that only addressing COVID or all three, the flu vaccines and RSV as well?
That website can help find other vaccines as well. But as with so many things have been in flux this season, there may be a day or so delay after certain supply lands before that My Turn vaccine locator can help you find everything you need. So if you're not finding what you need, giving it a little bit more time and checking back can be helpful.
Great. So we'll just have to get the word out to the public, myturnvaccine.com,
That's right.
right? Okay.
Thank you.
Thank you. Anybody in public? No?
Confirming no request to speak on item number 13.
Okay, good. Yes, go ahead, Sherry.
Great. Good afternoon, Chair Lee, Supervisor Abe Koga. You have my written report. The only additional verbal update I wanted to provide was we were very excited to have our ribbon cutting last Wednesday for Recover Gilroy. This is our newest behavioral health program, expanding access to substance use treatment for 600 to 700 individuals each year in South County. So we're really excited to have that program open. They are currently staffing, and we look to have services coming available mid-October.
Mid-October. Great. Thank you.
Thank you, Chair Lee and Supervisor Abihoga. You have our written report. I'm happy to answer questions.
Okay, good. Thank you. Any questions? Sure. All right, good. Great report. Thank you so much. And now I'm going to figure out what vaccines I need. And speaking of vaccine, the next event we're having that our office has sponsored every year, it's our 5th year now doing, is the Day on the Bay, which is going to be held at Alviso, same place, Alviso Marina Park, on October 4th in the morning, starting at 10 a.m. And I just want to also let people know that besides you could get there early to sign up for kayak or you know, wall climbing and all the fun stuff with your bike there, and you're getting your pumpkin for your kids as well. You can also get your flu vaccine there. That's yes, exactly. It was our 5th year that we're able to get vaccines out there. We won't be able to get COVID vaccine at location, but we will have flu vaccines. We're able to get that working. I want to thank our CEO, Judge James Williams, for making that happen. Really appreciate that. Okay, thank you for the team. And if no further ado, I will go ahead and move toward to the adjournment. The next meeting for HXC is scheduled for October 17th and Friday, 10 a.m. right here, same place, same channel. Thank you very much. Thank you.